طلبة المرحلة الرابعة السلام عليكم ورحمة الله. In this lab we will go through the physiology of pain and the strategies for the treatment of pain and an experiment to explain the analgesic effect of opioids. Pain can be defined, as we said before, as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. It might not be directly proportional to the amount of tissue injury. As we said, the quantification of pain is not easy. The experience of a person for a pain perception is completely different from someone else. So if we ask a patient to grade the pain intensity, it might be different from another patient for the same type of injury. There are two major types of pain. One of them is nociceptive pain, which is related to the activation of polymodal pain receptors, and this could be somatic in the, for example, the skin, muscles, soft tissues like the joints, or visceral tissue damage like the internal organs. And the other type is the neuropathic pain. Neuropathic pain is usually related to direct injury to the nervous system, to a nerve that will modulate or that will give a sensation similar to the sensation of direct injury to the tissue. The somatic pain arises from somatic structure, as we said, the skin, the muscles, soft tissues, and this could be superficial or deep like the joints. It is well localized, and it's transmitted. The pain induction is transmitted by the action of rapid unmyelinated nerves. We call it the A delta nerves. So the nerve will be sharp and well localized. For the visceral pain, it's usually originated from the viscera or the internal tissue. It could be related to inflammation, for example, or spasm. It is poorly localized. Someone will not feel the exact location of the injury in the tissue, and it's usually transmitted by the action of C fibers, which are the slow transmitting nerves. Visceral pain may be radiated or referred, which means the exact location of the injured tissue will not be confirmed. So the patient might feel the pain in an area while the exact inflamed tissue is in a different area or adjacent area. And usually it's associated with the involvement of the autonomic nervous system, like the excitation of vomiting or tachycardia. To understand the physiology of pain, we should understand the pathway of pain transduction. So for the pain to occur, there should be a stimulation of the high threshold neurons. These high threshold neurons include C fibers and A delta fibers. The activation of these high threshold neurons require the activation of nociceptive receptor by enough tissue damage to initiate an action potential in these high threshold neurons. So we have explained before the different type of nociceptive receptors that could be stimulated by a mechanical, chemical, or by thermal activation. So the transduction of the activation of action potential in the high threshold neurons will transmit the action potential to the dorsal horn, and in the dorsal horn, according to the intensity of activation or the action or the type of neurons, the pain will be transmitted or they conducted to the central nervous system through the spinothalamic tract, where the central nervous system in the thalamus and the brainstem and the cortex will integrate the type of pain and react according to the location and intensity of pain. In the dorsal horn, there is a mechanism that the system will differentiate the type of pain, or the type of neuron that have transmit the action potential. If the type of neuron is the high threshold one, like the C fiber and the alpha delta fibers, then the pain or the action potential will be transmitted to the upper central nervous system through the spinothalamic tract, while the low threshold action potential, the low threshold nerve stimulation, like the A beta fibers that normally transmit the normal sensation, like the hair movement or the minor touch to the skin. These will not be transmitted as a pain to the upper central nervous system. So let's review the type of nociceptive receptors. As we said, this could be due to high threshold, or the high due to high or thermal activity, like in heating, or it could be due to the activation of low pH chemicals, like the activation of acid, and it could be mechanical, or even low thermal activity, like in freezing. So all these are different types of receptors that could be activated due to these different types of stimuli. Activation of these receptors will initiate the action potential in the high threshold neurons normally, or usually these are the C fibers, to the dorsal horn, where the action potential could be transmitted to the upper central nervous system, where the pain, emotional reaction, or the modulation could occur. There are some processes that occur during the transmission of pain. These include: the first process is transduction, and the second one is transmission, and the third one is perception, and finally modulation. So transduction means the initiation of action potential by converting the type of injury to an electrical activity that be formed as an action potential through the proper nerve, and then transmission of this action potential or electrical activity to the dorsal horn, and from the dorsal horn to the upper central nervous system. So these processes are transmission, and then we have a perception of pain through the thalamus and the specific type in the cortex according to the location of injury, and then there will be modulation from the central nervous system, and this modulation could be either a mechanical activity to withdraw a hand or limb from the site of injury, in addition to a modulation of pain perception by activation of a specific mechanism to decrease the intensity of pain, like the activation of the descending inhibitory noradrenaline pathway, or the initiation or enhancing the synthesis of endogenous opioids that will act also as an inhibitory mechanism for the perception of pain. So the receptor and transduction of the nociceptive pain is due to that stimulation of the polymodal pain receptors by substances secreted from the damaged tissue. As we said, this could be mechanical, thermal, or even chemical activation. all these activations shared by releasing of chemical substances at the level of the receptor that will lead to activation of action, initiation of action potential. The transduction step is the process by which pain stimuli is converted to electrical energy, and this electrical energy is known as the transduction. This stimulus sends an impulse across the peripheral nerve fibers, like the C fibers, or we call it receptors, to the dorsal horn, and from the dorsal horn to the upper. To stop the pain perception at this step of transduction, we can use corticosteroids, for example, like dexamethasone, which are used for the nociceptive pain. The corticosteroids can interfere with the production of chemical substances at the injured tissue, like prostaglandins, which are sensitizers and enhancers of pain perception and pain initiation at the nociceptive receptors. Non-steroidal anti-inflammatory drugs also minimize the pain by minimizing the effect of trauma, by decreasing the release of chemical substances, especially the prostaglandins at the injured tissue. So you can see here the location of the effect of non-steroidals and corticosteroids at the level of pain transduction. So here non-steroidal anti-inflammatory drugs and also corticosteroids can interfere with the release of chemical mediators, like mainly prostaglandins, 5-HT due to inflammation, because these inflammatory mediators can potentiate the effect of noxious stimuli by enhancing the activity of C fibers and then the transduction and initiation of pain at this step. So at the step of transduction, we can use these non-steroidal anti-inflammatory drugs to decrease the perception of pain and producing analgesia. So at the step of transmission, where the delta fibers or the myelinated A delta fibers can send sharp, localized, and distinct sensation, and the C fibers or the unmyelinated fibers relay impulses that are poorly localized, burning and causing burning and persistent pain. Pain stimuli travel to the spinothalamic tract. So this is the pathway of pain transmission from the site of activation or the site of initiation in the nociceptors to the upper central nervous system. The perception is the integration of informations from the site of injury in the central nervous system, mainly in the thalamus and the cortex, where the person is aware of pain. Somatosensory cortex identifies the location and intensity of the pains. This is the perception, while modulation, in which inhibitory neurotransmitters like endogenous opioids, endorphins, and enkephalin, and the norepinephrine pathway will work to hinder the pain transmission at level of brain and the spinal cord. So this is the initiation of injury. Here will be transduction of this mechanical injury to an electrical activity by the action of nociceptors, and then transmission of action potential to the dorsal horn and then to the upper central nervous system, by the spinothalamic pathway. This is a transduction, and then will be perception and modulation of pain by increasing or secretion of endogenous opioids that will inhibit the or decrease the perception of pain by modulation on the level of in the dorsal horn. Also, we have descending inhibitory neurons that will release noradrenaline would affect the transmission of action potential to the central nervous system. So during this experiment, you will see the activation of receptors by injection of chemical substance at the peripheral tissue. So first step, we are going to use either we can use mice or rat. In this experiment, we are going to use rats. So during this experiment, we should record the body weight of the animal, and then we should put a mark on the hind paw that will be injected with the chemical substance to induce pain, which is formalin. Formalin will be prepared as a 5% solution using saline, and then we will inject a 50 microliter of the 5% formalin solution using a 0.5 ml syringe. In this process, we should restrain the animal movement when doing the formalin injection, and then inject the 50 microliter solution of the formalin in the dorsal surface of the paw by placing the needle above the toes and below the ankle, and inserting the needle beneath the surface of the skin. Then formalin will evoke two spontaneous responses due to the sensation or initiation of pain at the area. These include flinching or shaking of the rapid movement of the limb itself to where the animal will try to get rid of the noxious stimuli, and then licking or biting in order to decrease the sensation of the pain on the injected paw. In this experiment, one animal is giving pethidine or mipridine, which is an opioid, and a dose of 10 milligram per kg 30 minutes prior to the injection of formalin. This is to show the analgesic effect of opioids at the level of the dorsal horn on the central nervous system. And then the other animal will not be given pethidine, so we will see the difference between we will see the analgesic effect of pethidine on one animal, while the normal reflexes of sensation of pain in the other animal. So this is the location where the animal limb will be marked and then injected by 5% formalin. Thank you for your listening, and I hope you will understand the analgesic effect of opioid through the next video. Thank you so much. الأولى في التجربة خاصة بالassessment of opioid in the management of pain على الانيمالز هو وزن الرأس اللي راح نستخدمه. طبعا حمل الرأس يكون بهالشكل. وزن الرأس الحالي
هو 258 غرام. حسب وزن الرات هي عبارة عن 10 ملغ بير كي جي. فحسبنا الجرعة وسحبناها من مادة البيثيدين وراح نعطيها بشكل انترا بريتونيوم. الطريقة الصحيحة لمسك الرات بالانترا بريتونيوم تكون بهالشكل. يعني تكون قبضة أحد اللمس الأبر لمس تدخل من تحت الأصبع والثumb يصير بهالشكل هذا، بحيث يعني يتم مسك الانيمال بدون ما يتحرك، ولا ممكن بانه يعضل للشخص اللي ينطيه ادمنستريشن. فاذا يتم مسك اللور لمس بشكل بحيث تسحب لي هذا اللمس وهذا اللمس عكتين، والمنطقه اللي يصير بها ادمنستريشن بهالشكل هذا انترا بيريتونيوم، يتم حقن الماده وتسحب. تحرك بشكل بسيط ويترك الراس حتى نشوف التأثير ماله. هسه راح يتم حقن مادة الفورمالديهايد
بس الطلاب الآن الراقب اللي بعد أن حقنا الفورمالين نشوف الشيكينج. لاحظوا شيكينج بهذا اللم اللي سوينا لها انجكشن، بيسوي لها شيكينج ويسوي لها ايضا فليكينج وشيكينج وليكينج وبتنج. لاحظوا شلون هسه بيسوي لها شيكينج، لاحظوا بيسوي لها ليكينج، لاحظوا بيسوي لها ليكينج الان. راح يحس بس
شلون نزلها دكتور؟
انا فوق تضرب وياها.
اي انا الرات الثاني فورمالين يعني ماكو رفلكس من عنده، يبدو بانه تاثير البيثيدين قوي لا زال عليه، ما يحس بالبين. واحدة من الطرق ايضا اللي ممكن بانه نسوي اندكشن للبين، ما عنده هذا الرفلكس اللي ممكن بانه يصير. يعني هذا الرات الاخر اذا سوينا نفس الحركة نفس الاندكشن اللي يصير اكو صوت يحس بالبين، يحس بالألم. تلاحظون هذا الرات اللي انطيناه بيثيدين شلون؟ اكيد هسه اكو يوفوريا. رفلكس قليل بالتأكيد. السنسيشن اوف بين ماكو، قد ما اضغط على اللمس ماكو رفلكس، معناته بانه ما يحس بالبين. بعد ما وصل مرحلة الريسبيراتوري باراليسيس او الدبرشن. اكتيفيتي مالته كلش قليلة مقارنة ببقية الراس، يعني اذا نوضع رات اخر يمنا اللي ما اخذ البيثيدين نشوف قد اكتف يتحرك. بينما اللي اخذ البيثيدين شوف الريسبونس مالته ايش قد كان. إذا نسوي اندكشن للبين شوف شلون اكو يصير ريفلكس.